Presenting at a median of 10 years after surgery, breast implant-associated anaplastic large cell lymphoma is a new classification of lymphoid neoplasms that is the subject of this review article from authors at the Royal Marsden Hospital and University of Exeter Medical School in England. The entity is characterized clinically by the development of a peri-implant effusion, seen in 85% of cases, or less commonly as a unilateral peri-implant mass arising more than 1 year after textured breast implantation. The theory is that the lymphoma, which shares similar immunopathologic characteristics with systemic and cutaneous anaplastic T-cell lymphoma, derives from chronic inflammation and persistent activation of T-cells reacting to a gram-negative bacterial biofilm arising in the breast implants. Table 1 provides a list of the differences between this rare form of lymphoma and other histologic subtypes of non-Hodgkin lymphoma. The differential diagnosis of a late periprosthetic fluid collection includes hematoma, infection, implant rupture, and capsule bleed. Cytologic fluid analysis is necessary for diagnosis in those with effusions, while those with a mass-forming lesion require percutaneous core or excisional biopsy for diagnosis. Immunohistologically, the tumor shows CD30, CD2, and CD4 positivity, but is CD3 negative. The malignant cells are large and atypical on high-power photomicrography. Multimodality imaging is necessary for proper staging and prognosis and to assess treatment response. Table 2 provides a summary of the strengths and weaknesses of various imaging techniques in assessment of this entity. Note that mammography provides little useful information in the diagnosis of breast implant-associated lymphoma. Breast ultrasound is the initial test employed for evaluation of swelling or pain related to an implant. Breast-associated lymphoma typically manifests on ultrasound as a peri-implant effusion or an oval hypoechoic well-circumscribed solid mass that lacks hypervascularity. 2 patients with different ultrasound appearances are shown in Figure 2. It is important on ultrasound to assess for the presence of local, regional, or supraclavicular adenopathy. Ultrasound allows evaluation of the contralateral implant and can guide fluid sampling and fine needle aspiration cytology. Computed tomography shows peri-implant effusion or mass-forming disease and can detect rare bilateral involvement. There may be an irregular contour or infolding of the implant indistinguishable from implant rupture. The principal value of CT is in the detection of locally advanced disease such as chest wall invasion, local regional involvement, and distant disease. Breast MRI is the second imaging study of choice following ultrasound for diagnosing breast implant-associated lymphoma, as it can depict the presence of an effusion and even small volume peri-implant mass lesions. PET-CT with FDG is useful as a staging tool in non-Hodgkin lymphoma. Regarding preoperative workup, in Figure 11, the authors offer an algorithm for the preoperative diagnosis and staging and postoperative assessment and surveillance for effusion-only and mass-forming types of disease. In distinction to virtually all other lymphomas, surgery is the first-line and potentially curable therapy in the peri-implant effusion subtype of disease, while systemic therapy is utilized for mass-forming lymphoma and when there is invasion of surrounding tissue, lymph node involvement, or distant metastases. Prognosis for those with surgically resectable disease is excellent, but is lower in those with the mass-forming subtype. Routine imaging surveillance for the peri-implant subtype is not currently recommended.